I think all of us in this room know that pathologic downstaging at the time of cystectomy is associated very strongly with long-term survival in patients with muscle-invasive disease. Here are the survival curves from SWOG 8710, neoadjuvant MVAC followed by cystectomy versus cystectomy up front. And if we stratify the survival curves, what we see is really that the patients who are pathologic complete responders were the ones who really had the most benefit. 5-year overall survival of close to 85%, and around 35 to 40% in patients who had residual muscle-invasive disease. And then a similar sort of retrospective analysis of neoadjuvant gemcitabine and cisplatin showed very similar findings that any degree of downstaging at the time of surgery following cisplatin-based chemotherapy was associated with improved long-term survival in patients. And so the question that came up about 10 years ago when the, NGS was really having its heyday was, are there certain genomic alterations that can predict for pathologic downstaging in patients after cisplatin-based chemotherapy in the muscle-invasive space? I will go through this fairly quickly. I know it's a busy slide, but basically a group from Dana-Farber as well as MSK decided to do an outlier analysis in patients who had muscle-invasive bladder cancer to try to identify genomic alterations that would be predictive for response or chemotherapy response. So they identified 25 patients who were complete responders or had just residual CIS at the time of cystectomy, another 25 who had a T2 or greater disease at the time of cystectomy following neoadjuvant cisplatin-based chemotherapy. And these patients had a mix of dose-dense MVAC as well as gemcitabine and cisplatin chemotherapy. And they went back and looked at their pretreatment TUR specimens, performed whole exome sequencing. The sort of genomic profile, which is what you see on the bottom left there, was pretty similar to what you see in TCGA for muscle-invasive bladder cancer. But the big difference was that in patients who had ERCC2 alterations, they were all sort of responders to chemotherapy. So there were 9 patients out of the entire group of 50 who had ERCC2 alterations, and all 9 of them were responders. None of the there were no ERC2 mutations in patients who had T2 or greater disease at cystectomy. What's interesting is that if we look across multiple tumor types, ERCC2 alterations really do seem to be a bladder-specific phenomenon to some degree. We can see that there's anywhere between, actually, if you look at multiple data sets, that anywhere between 8 to 12% of bladder tumors that have ERC2 alterations versus only about less than 5% in most other tumor types. So what does ERCC2 do? It is a DNA helicase that unwinds DNA around the sites of DNA damage, and that can be damage from UV light, tobacco, platinum use. The specific type of lesions that form following that type of DNA damage, ERCC2 recognizes that, it binds to that area, it unwinds the DNA, and basically allows a number of other factors and proteins to come in there to fix the DNA in a multi-step process and allow for just a clean double strand of DNA remaining behind. Interestingly enough, there are actually known autosomal recessive disorders in patients who have germline ERCC2 alterations. The big one that you probably all have heard of is XP or xeroderma pigmentosum, and as well as a few others like trichothiodystrophy, Cockayne syndrome. All of these syndromes, they are distinct, but they also have certain commonalities, which is that there's a hypersensitivity in these folks to UV exposure, not surprisingly, as well as pigmentary changes and rapid skin aging. When we take ERCC2 alterations that have been reported publicly and sort of map them along the entire protein, which is the top right, what we find is most of these alterations are point mutations, and they do cluster in specific sort of conserved regions of ERCC2. And most of these regions are thought to be involved in that unwinding process. So if you have mutations that are within these helicase domains, it interferes with the unwinding of DNA around DNA damage, and therefore you don't get as efficient repair of DNA damage. If you take cell lines from patients who have xeroderma pigmentosum, what we find is that they're extremely sensitive to cisplatin chemotherapy. They have very low IC50s, but if you actually put back wild-type ERCC2 in those cell lines, you kind of correct that cisplatin sensitivity phenotype, and all of a sudden they're not as sensitive to cisplatin chemotherapy. This is a lot of data that I won't go into in too much detail, other than to say that using sort of in vitro cell line models, they were able to find that when you lose ERCC2, the sort of efficiency of DNA repair is impaired significantly in multiple cell lines and using multiple mutations within ERCC2. And the same data was shown in mice as well when they were able to orthotopically implant mice with cell lines that had ERCC2 mutations. These tumors were much more sensitive to cisplatin chemotherapy than the sort of parental cell lines as well. So a lot of laboratory data, but how can we try to translate this into the clinic? So, Dr. Plimak and colleagues at Fox Chase also found, using a similar sort of outlier analysis, that there were other DNA damage response genes that were associated with exquisite sensitivity to neoadjuvant cisplatin chemotherapy. Specifically, they found that ATM, RB1, and FANC-C, which are also part of other DNA damage response pathways, were associated with increased sensitivity to neoadjuvant chemotherapy. They used a panel, an NGS panel, as opposed to doing whole exome sequencing, and that panel actually did not include ERCC2. So then they went back and sequenced ERCC2 within their samples as well, and found actually that yes, that's also they were able to validate sort of the same findings as the Dana-Farber MSK group as well. What's also interesting is that when you combine the two cohorts and look at just overall survival, there seems to be a better overall survival in the patients who have ERCC2 mutations. So whether it also has some sort of prognostic biomarker indication or not, it's unclear, because we're also talking about patients who received cisplatin-based chemotherapy. So it could just be a very strong predictive biomarker of outcomes as well. And then data from a smaller study of neoadjuvant dose-dense gemcitabine and cisplatin, which was used as explored as an alternative method of neoadjuvant chemotherapy. NGS was performed in the pretreatment specimens of these patients as well, and we also found that actually DNA damage response gene alterations were enriched in responding patients, and that DDR gene alterations were associated with a much improved recurrence-free survival and a higher TMB as well, compared to DDR wild-type tumors. And then Eugene Pietzak actually has had some interesting work where he compared the genomic profiles of what we call primary MIBC tumors, which are sort of de novo tumors in patients without a history of non-muscle invasive bladder cancer, versus secondary tumors in patients who had a history of NMIBC treated with BCG therapy. And when we just look at survival, the recurrence-free and overall survival are markedly better in the patients who have primary MIBC compared to secondary. And then when we looked at the sort of genomic profile and compared secondary versus primary MIBC, not a huge amount of difference, but interestingly, ERCC2 alterations again popped out as being only found in primary MIBC tumors, not in secondary MIBC tumors. And when he also looked at a cohort of patients who received BCG therapy for non-muscle invasive disease, their non-muscle invasive tumors that were ERCC2 altered tended to have a much better recurrence-free survival than those that were ERCC2 wild type. So there's this possibility that maybe ERCC2 alterations, might confer sensitivity to BCG therapy, and therefore maybe selectively being eradicated in these tumors. And when patients develop recurrent disease, they're probably going to be ERCC2 wild type secondary MIBC tumors, so to speak. Data that I'm not showing here also by Neil Desai, now at UT Southwestern, but when he was at Memorial, also was able to show that there's this strong correlation between ERCC2 alterations and sensitivity to radiation treatment in bladder tumors that receive RT as well. So actually, the RETAIN-1 trial, which is the PI is Dan Geinesman at Fox Chase, this was the first trial that actually tried to leverage these data and apply them clinically. So this is a trial of bladder preservation with chemotherapy alone in biomarker-selected patients. So patients who had clinical T2 to T3 node-negative disease and had a urothelial predominant histology were eligible for this study. They would undergo an initial TURBT. They would have sequencing performed through Caris, and then at the same time, they would undergo neoadjuvant chemotherapy with accelerated MVAC for 3 cycles. If they had a mutation in any one of 4 genes, ATM, RB1, FANC-C, or ERCC2, and they had a clinical T0 response, meaning no residual tumor on a second TURBT, urine cytology that was negative, and imaging that did not show anything suspicious, then they could be offered what's called active surveillance, where basically they would be monitored carefully with cystoscopic evaluations, urine cytologies, and imaging, but not undergo a radical cystectomy. And then if they had anything else, you can see that they were actually stratified into 3 different treatment options, either intravesical therapy, chemoradiation, or cystectomy. If they had residual muscle-invasive disease, then chemorads or cystectomy. And then if they had T3 or greater disease clinically, then cystectomy. The primary endpoint was a 2-year metastasis-free survival. And they had 70 patients included. What was interesting is that 33 of these patients were mutation positive, and of those, most of those were clinical T0 versus, it was about a 76% rate of clinical T0 in the mutation positive patients versus about 15% in mutation negative. And the final 2-year MFS was 72.8%. The lower bound of the 95% confidence interval was 62.8%. Unfortunately, the statistical design for the study was that it needed to exceed a lower bound of 64% in order to be considered positive. And so they had to say that this risk-adapted approach could not be declared non-inferior to a standard approach of neoadjuvant chemotherapy and radical cystectomy based on that statistical design. And finally, one other piece of data that I just wanted to quickly mention, there has been a secondary analysis done of SWOG 1314, which was a study of dose-dense MVAC versus gemcitabine and cisplatin, followed by radical cystectomy for patients with muscle-invasive bladder cancer. And so we looked at tumor specimens, the pretreatment tumor specimens from these patients, performed NGS on those, and correlated the rates of DDR alterations with survival outcomes, and found that it wasn't statistically significant, but there were definitely trends towards improved PFS as well as OS in those patients who had ERCC2 alterations as well as DDR gene alterations in general. That's actually my last slide. The one thing I will say is, specifically about the RETAIN study and some of the other bladder-sparing studies, I want to actually maybe echo what Dr. O'Donnell mentioned this morning about the non-muscle invasive bladder cancer space, that now that we're doing more organ sparing, there are more recurrences that are happening. And so, this study, the RETAIN study, was a 2-year metastasis-free survival. I mean, we clearly need to see much longer-term outcomes before we could actually say that this type of approach is safe for patients. So more to come. Thank you.